Looks like we do. You're only missing Dr. Kane and Dr. Welsh, who I think is showing up later.
Okay. So we have a quorum. And then our agenda today, I'll be going over here in a moment. But the main thing about the agenda for today is that we are going to be focusing on the workforce and strategies for improving workforce here in Indiana. I can tell you that we need a strong workforce. There's nothing more important or more fundamental to any organization than their workforce if you want to achieve the mission and have excellent work. So I'm quite excited about hearing our presenters today that will be speaking on workforce in Indiana. And we'll have, I know, a number of questions before we get into that. And we'll also be talking about the communications plan and public engagement. At the end of our time, the last 30 or 40 minutes or so, we'll have plenty of time for questions after we have our presentations to discuss. We do need to have a motion for approving the minutes. So do we have a motion to approve the minutes of our first meeting?
Second.
I have a first. Did you note those? Shane?
Second.
Second. Thank you. All in favor of approval?
Aye.
Aye. Any denials? Nays? Okay, so we've got approved minutes. And let me turn to Senator Luke Kenley, my co-chair, to see, do you have any opening remarks that you'd like to make?
Well, thank you, Judy. And thank you all for coming back. We didn't scare you away enough that it's interesting. The governor asked me to do this, and I said, "Gee, Governor, you can just do what you want. You're a lame duck governor. You can go play golf. Why are you taking on an issue like this?" And he was explaining to me why it was important to him. And I said, "Well, I guess if it's important enough to you, then I should go ahead and agree to get involved." So we're all here. And the longer I think about this, I think the more just and necessary our cause for action is, and I know we'll have a great report for this. I do want to add one thing. I think each of you needs to think about what associations, what groups, what elected officials in the state legislature you have that you can keep them posted, let them know that you're engaged in this activity, tell them what you think about how we're doing and what the positive developments are. There is so much controversy surrounding the current pandemic that we're all going to have to work together to pull this through just for some basic things that really catches Indiana up with where healthcare is in the world at large. If you look at the gross domestic product share that goes to healthcare, it's way beyond any public healthcare resources that we put out there. So that's our mission, and I hope you'll join me in that. I do want to note that Monday night I'm on the board of directors of the Independent Colleges of Indiana, and they had the Indiana Academy dinner, and they were so grateful to Dr. Box for all the help that she had given during the pandemic that Trine University gave her an honorary doctorate degree. And then I understand that the Luger Series, Women's Series, gave her the Nancy Maloney Award, which if any of you knew Nancy, she was a great person. And so I think we've got great leadership at the helm, and congratulations, Dr. Box, on those achievements.
Thanks, Senator Kenley. I think myself and the department and many other people have worked harder to get this doctorate through the pandemic than I did originally on my first doctorate.
Yeah, so well, congratulations. Before I turn to Dr. Box, I want to let you all know that a lot of folks I've mentioned last time have been calling about what Indiana's doing. I'm getting phone calls from many states asking to see the executive order and what's happening in Indiana. But just prior to this, I realized I had scheduled myself to be a panelist on a global health philanthropy global meeting just prior to this. So I had to set up a room, and it turns out I was, of course, worried about the technology. My technology worked fine. I got on just fine. But my fellow panelist was unable to ever get on. So what was supposed to be maybe 20 minutes of comments for me ended up 45 minutes. And they asked me, they said, so where are you today? And tell us why you're in Indiana. So just so you know, I did talk a little bit about the Governor's Public Health Commission on the Global Philanthropy Forum today. So if you hear about that, so
awesome.
we're going to make you even a bigger star.
That's all right.
But with that, yes, so let's turn to Dr. Box for the communications.
Thanks, Dr. Monroe. So I have to echo Senator Kenley's thoughts, and that is we really need you to retweet information. I don't know if you noticed, I just got on Twitter, and the purpose of that is really to talk about what public health is, because I do believe that people have the wrong impression that public health is mask mandates and vaccine mandates. And it really is not. I mean, we've been doing public health, Mindy and Paul Halverson, a lot of people around this table can tell you how long we've been doing public health and the different things that we do that have had nothing to do with pandemics, thankfully, in the past 100 years. So the more that we can get that information out on your social media and that you share that, I think the more individuals across our state, Hoosiers, will understand what public health is and what we're doing. It's really important to us too, I think, that you, since you represent large networks of individuals across the state of Indiana, whether that's the Minority Health Coalition or local health department administrators or a rural health association or public health associations, that you bring back to us their thought process, their impressions. I really am interested about the reactions that you guys are finding. Is there an understanding of what we're trying to do, or a misunderstanding of what we're trying to do? And who and how do we need to change our messaging so that we make sure that we really are adequately and appropriately representing the purpose of this commission? We did talk a lot about how we will engage the public in kind of our communication strategies. And you all had this in your packet. Hopefully people had the opportunity to look at that on the back, or kind of our listening tours that we had set up. And part of it is our website, which is already up and running. I hope you guys will go to the website. You can go to indiana.in.gov/GPHC if you, or yeah, Governor's Public Health Commission. Yeah, if you want to, or you can just go to the in.gov website and put it in as search if you forget the rest of that. But on there, you'll see information about yourselves. I think, Shane, we were talking about getting bios on individuals so that people would have an idea of, okay, who is the Honorable Bob Courtney and what does he do and what does he represent, so that they'll know the different individuals that are engaged in this process. Also, information about our past meeting. They'll actually be able to get on and listen to that meeting if they would like to see the video. Information about the upcoming meetings, and the information that we gave out today will be there for people to review all those documents that we gave out and the slides that are going to be presented. So the website is very important. The other thing that's there, besides the fact what the next meeting will be and what we will be covering, is that there's going to be the opportunity for individuals to actually get on and comment about the Public Health Commission and to give their comments about the particular topics that we have chosen to discuss. And we will be looking at those in between each meeting and then kind of condensing those comments down and sharing those with you so that we don't have to send all of them to you to review, but we'll give you representative comments from the different things that are said. And I think that's important because that will give individuals all over the state of Indiana to comment on what we have said at a time that we can actually, again, distill those and give that information to you. So we have certainly opened that avenue and have been discussing that. So I would encourage you to also share that with your different networks. The social media, I've already mentioned the tweeting, the stakeholder meetings. There are stakeholders across the state of Indiana that we know we would very much like them to have a definitive understanding about this commission and what it's trying to do. And so Senator Kenley and I will be going out and talking to the chamber, talking maybe to the hospital association if Brian would let us come, would be talking to CICP and other individuals to kind of give just a condensed version of what we're doing here and the different information streams that we're addressing. And then to give them a charge with regards to, we would love to have your support and your engagement as we go forward. So those will be starting up here in the next month. probably even at the end of October and going through the next winter as we go forward. We also are doing the listening tours, which again are listed on the back here. We tried to make sure that we picked an urban area, a suburban area, and then a lot of our rural areas, because we felt like that's a very important aspect, a very important part with 49 rural counties, and certainly some difference in services across the state, depending on where you live. So we'll very much be sending out very specific invitations to some individuals like mayors and county commissioners and the county counselors in those areas, hospital CEOs, large businesses in those areas. We'll include education in those areas, so superintendents. Certainly, when we're in rural areas, I would say, Kara, we would love for you to be able to be available with those. Of course, we will be inviting members of the commission to attend any and all of those that you would like to. And we wanted you to have the dates so that if you wanted to set those aside. But certainly, Dr. Monroe, myself, and Senator Kinley will try to be at each one of those also. And that truly is a listening tour. That is not for us to try to defend or explain the way certain things were done during the pandemic or the way public health is. It's to listen to Hoosiers all over our state that have been impacted by this, but also that understand public health in their communities and want to share that. And then we also have planned legislative updates, and that will be, we actually are sending out information in the form of a kind of a media information before the meetings as to what's going to happen, and then afterwards a press release as to what was discussed and links to all of the data and the information, the slides, et cetera, that we give out. And at the same time, Senator Kinley will be kind of distilling that along with Micah Burkert, who is our legislative director, and they will be sharing that, Senator Kinley, both in writing, probably by email, but also directly in phone calls with our leadership in the Senate and the House, and also with the leadership in our House and Senate committees for the health. I am making myself available and hoping that maybe every 2 to 3 months, they might like me to come personally along with Senator Kinley and maybe just kind of update them on where we are and what we've discussed. But we're really leaving that up to them. As long as they feel engaged and informed, we think it's important that they're kept up on what we're doing. And I think that's pretty much what I wanted to run through. Are there any questions or maybe additions that we've forgotten, things that you think really should have been included in the communication?
You know, I would comment, Chris, in addition to what you said there, we're trying to reach out so that we can get explanations to the leadership of some of these associations and people who do lobbying. And we would probably like to try to reach out to the county commissioners, the mayors, the county council, maybe even their leadership at least, and if not in a live meeting, in a virtual meeting, so that we can get our message to them. And in reality, I think our message is broad enough and strong enough that we think that people should be behind us. And I'll probably be asking them in some sort of a framed way to say, well, we'd like for you to keep track of what we're doing. And we'd also like an endorsement from you with our legislators so that you can work with them as well as us. And then that way we get everybody rowing in the same direction here in Indiana over something that we have all agreed on is the right thing to do.
Thank you. Brian?
Yeah, Senator, if I might, I mean, along those lines, would it be helpful to, because I've been, and I'm sure others have, contacted by some, other groups, whom we engage and collaborate, to say, hey, would you help carry forward a message, or here are some thoughts wanting to share with the commission? So if we kind of maybe reported back to kind of keep a list of some of those groups that we know are already actively interested in the work of the commission, and then just sort of build on that list.
I think that's great.
Okay.
No, that's terrific. I think Mindy, did you have a comment?
Yeah, I was wondering if you wouldn't consider maybe including reaching out to county councils and city councils, the ones that control the money, in addition to the commissioners and mayors, because having all 3 or 4 bodies on that same page and getting your buy-in would be great.
Okay. That's what we talked about, at least on the invitations too, for our listening sessions, including them, Mindy.
Very good.
But
Great.
certainly, if they have a large association, we could have a time to talk with them too.
Kim?
Yes, I will just offer also that through the Indiana Public Health Association, we're convening what we call an action team, which is basically open to people who are interested in joining with a group to follow along with the commission, agree to monitor kind of the discussions here, think about priority issues they want to bring forth and that kind of thing. So anybody watching or that kind of thing, if you all hear of people that are interested in kind of a committee type to track along, we are convening that. So they're welcome to reach out.
Thank you. Anyone else? Yes.
Yes, I've got a question, I guess. I've had contact from some different individuals, and they have sent me some information that if it's okay, I'll give it to Shane. And then I didn't want to send it to everybody because we have our emails, but I thought I should at least ask. And so one is an article from the advisory board, which is a national organization, and the other is from the University of Wisconsin Public Health Initiative, I think it's called. And it's more of a chart that goes along with what Dr. Halverson presented to us at our last meeting as well. But I'm not saying I agree with this, but I think it's information that probably would be helpful. So I'll give it to Shane and you can send it around. Thank you. Yeah.
Thank you. Anyone else? All right, thank you, Dr. Box. So moving through the agenda, we're very fortunate to have some excellent presenters today with deep knowledge of Indiana's public health workforce. We're going to be looking at the gaps and the insights. Courtney Medlock from the Bowen Center for Health Workforce Research and Policy at Indiana University School of Medicine, and Valerie Yeager, Department of Health Policy and Management at Indiana University Richard M. Fairbanks School of Public Health will be presenting, and we're starting with Courtney. So Courtney, over to you.
Thank you. Can you hear me okay? Yes, great. Good afternoon, everyone. It is an honor to be here.
Yeah.
My name is, oh,
Yeah, the mic needs to be a little louder. Is it on?
hello? Is that better? Closer? Oh, my.
Oh, there we go.
Oh, my. Okay.
Now you get.
All right. Okay, I'll also speak louder. Good afternoon, everyone. It's an honor to be here today. My name is Courtney Medlock, and I serve as the Assistant Director of Policy and Strategy at the Bowen Center for Health Workforce Research and Policy. I'm presenting to you today on behalf of our center's director, Dr. Hannah Maxey, who also serves as a designated policy advisor and is a commission member here. Hannah sends her deep regrets that she's unable to join today. She had a prior family commitment that she had to honor. So I am grateful to be able to present in her stead. Before we start off with this presentation, on behalf of myself and Hannah, we'd like to first thank the commission for the opportunity for our team at the Bowen Center to present. We are passionate about translating data into tangible and actionable policy considerations for the state of Indiana, and we hope this presentation does just that. We'd also like to thank the many individuals that we met with over the course of the last couple of weeks to discuss these important issues. We hope that the information we have prepared for you today is an accurate, synthesized reflection of all that we've learned in the past few weeks, coupled with the expertise we have in the healthcare workforce space. All the information we'll be presenting today was also included in the memo that you received last week. And I do apologize, we recognize it was quite lengthy, but we wanted to do our due diligence to share all of the information, rationale, and considerations for your reference. Now, for those who are not familiar with the Bowen Center, we are a center housed in the Department of Family Medicine at the IU School of Medicine. We work under contract with the state of Indiana to steward health workforce data provided by the Professional Licensing Agency. I'm going to talk a little bit more about the data that we steward, but the information that we maintain gets put into data reports and briefs on the health workforce, and it is used by stakeholders internal and external to state government to inform policy and programmatic decisions. The Bowen Center also staffs the Governor's Health Workforce Council, which I'm also going to share about later today.
Courtney, can you move that podium forward toward us a little bit to the whole podium? Shane, it's just a little hard to
Yes, a little too
hear.
far.
A lot of echo in this room.
I'm sorry, I feel like I'm eating this microphone, but is that better?
Yeah.
Yes, okay.
Probably have to have your mouth right on that mic.
All right.
There
My
you go.
apologies. I will be right here and I will not move. All right. Let's start off with level setting on who or what we're talking about when we say the health workforce. The health workforce is comprised of both the healthcare workforce and the public health workforce. When we're talking about the healthcare workforce, we're talking about roles that are commonly associated with healthcare delivery, such as nurses, physicians, dentists, et cetera. Among the health workforce, there can be those that are engaged in clinical care, and there are other roles such as research, teaching, or healthcare executives. When we're talking about the public health workforce, we're talking about roles that work in traditional public health settings, such as epidemiologists, laboratory specialists, environmental scientists, et cetera. There are also some individuals whose roles overlap between the public health and healthcare workforce. The darker green portion on the slide represents the overlap, or those healthcare workers that are also engaged in public health. These individuals may be public health nurses, local health officer physicians, health educators, et cetera. I'm going to turn it over to Dr. Valerie Yeager in just a minute to describe more about the public health workforce. But before I do, I want to quickly reference this diagram about Indiana's local health department workforce provisions and structure. This diagram was prepared based on a review of Indiana code as to the relationships between all of these different entities. And it was distributed to the commission in advance for your review. I think it provides a clear example as to why we must talk about the healthcare workforce and the public health workforce in unison. It's evident on this diagram that there are numerous roles that overlap from the previous slide. The local boards of health are comprised of at least 2 licensed healthcare professionals, physicians, and may include additional licensed health professionals. Additionally, the local health officer at the local health departments by Indiana code must be a physician. Additional information, including code citations, can be found in the memo prepared on this topic. Because conversations regarding local public health infrastructure are closely tied to workforce, we advise that the information in this diagram be revisited during the infrastructure discussions. I'm now going to turn it over to Dr. Valerie Yeager, who's going to share more about what we know about Indiana's public health workforce.
Hi, everyone. Very nice to be here. I'm Valerie Yeager. I'm an associate professor in the Fairbanks School of Public Health on the IUPUI campus. And I'm so glad to be able to talk to all of you about the kind of stuff that I do for fun. So here we go. You'll note that this includes a little bit of overlap of some of the content that Dr. Halverson presented last week, or I guess last time you guys met, which has to do with the report that he and I co-authored last year, which I believe contributed a little to the starting of this commission. So we're going to start by looking at this colored map of the different districts within the state to begin the conversation about the context that the workforce exists in, which is situationally the structure of this system, how many health departments we have, the types of services that are being provided within our health departments, and thereby what is available to the communities that they're serving. This relates directly to the numbers of employees that we have in those health departments, as well as the skills that they are bringing to the service provision within their agencies. So I'll cover a summary, a very high-level summary of that today, though there are a lot of resources I can provide if anyone wants further information. So part of what we're going to draw some attention to is how we're training, what job training needs there are and what we know about it, recruitment issues and retention issues within the workforce. And we do fortunately have some insights about Indiana. But I will get to the punchline really quickly. We're missing a lot of information. So let me start with this table, which was meant to summarize what were 3 really lengthy slides into one. So we essentially have 3 types of data that are available to us to understanding the public health workforce in Indiana. The first column is what's commonly referred to as the Public Health Wins Survey. This is a survey that was initially conducted in 2014, led by the Association of State and Territorial Health Officials, or ASTO, in conjunction with the de Beaumont Foundation. This survey is the first time that individual employees of agencies were surveyed in our nation. And they continue to conduct this survey every 3 years. So they currently have this survey in the field right now. And we're actually lucky that the Region 5 Public Health Training Center has advocated to oversample our region, which includes Indiana. I'll get to a little bit about that in a moment. So the difference between this data and the rest of the data I'm going to show you is that the workers themselves tell you what they think, what their skills are, how long they've been employed, their likelihood to stay in the workforce, and so on. Historically, the State Health Department has been surveyed in Indiana and Marion County Health Department only. This year, there are another 12 local health departments who are being asked to complete the survey, though to date, and the survey closes at the end of the month, by the way, one of those 12 has no responses. One of those 12 has 88% response. So there's a lot that are hanging out right at around 40% response. So if they give us their perspectives, we'll have a little more information, but 12 out of 94 isn't many. So we don't have a representative response from individuals that are in the workforce. Now, the Region 5 Public Health Training Center also conducted a survey last year. So in 2020, it was the first time they surveyed in the region, and they asked questions about training needs. They specifically sent these surveys to the health official, and in many cases, the health official had an administrator help them to complete the survey. This looked more at what are your skills and what are your gaps. And like I said, first survey that we've had on skill gaps within our workforce, but only 35 of Indiana's 94 local health departments responded. I think there's a typo on that slide. So only 35, about a third of our health departments responded to that survey. I'll present some of the findings that we have from it, but again, not representative of all of the health departments. And then the last column is a survey that is, I believe, administered through folks at the IDOH, but is also, we have a member of the commission who has a big role in this survey and has helped to design it. So this survey is an annual survey of the local health departments in the state. An administrator or a representative of the administrator completes the survey, and it includes things like how many of the following employees are full-time, are part-time, what are their salaries, what does your budget look like, and what types of services did you provide, and what fees did you collect. What this gives us is some information about who the workforce is. It also provides some financial information. What it doesn't do is tell us what the barriers are. So what are your challenges in hiring? What are your recruitment or retention issues? And I will say that there are some data validity and reliability issues with this survey, because as I've worked with this data to complete the public health system report last year, we found some inconsistencies in how some of the health departments report financial data. So there are some challenges in using that. So what does this mean? We have these 3 data sets that are specific to Indiana. I could go on and on about what we know about the national public health workforce, but to be specific to Indiana, we have a bit of a foggy picture. We've got some data that can give us some information, but it doesn't present a clear path. So here are the workforce characteristics in sum. We've got 94 local health departments, and you can see from this slide, and that yellow box isn't as obvious on this presentation as I had hoped it to be. But those top two lines in this table are the majority of the health departments. So 65 or 70% of our 94 health departments are serving populations of 50,000 people or lower. On that, what that means is we have an average of 5 employees across 65 of our 94 health departments. And you might note that in the part-time employees, some of the smaller ones have as many as 11 part-time employees, and some of the small ones have as many as 0 full-time employees. That gives you a sense of how small 65 of our 94 local health departments are. In the survey that I mentioned that is representing the local health departments from their budget and their workforce information, they are asked to provide full-time, part-time, and financial salary information about those 8 positions that are listed on the left. For anybody who can't see that, that's the chief executive, the finance officer, payroll administrator, food inspector, director, septic, public health nurse, vector control, vital records, and other chief or manager director staff. Then that relatively small list of 20 other occupations is also asked about. But what I want to highlight for you is the note at the bottom. There are no questions about epidemiologists or individuals with informatics skills that would facilitate using data for evidence-based decision-making. None of that is on the list. A little bit of information about our local health officers or officials. We know that among our local health officials, 55 of them are part-time and 39 of them are full-time in their agencies. Typically, the full-time roles are in those larger agencies across our state, and the smaller local health departments tend to have part-time officials who often serve as in a clinical role as a physician in a full-time capacity, and then support the local health department as needed. So we have some insights into our workforce demographics. Now I'm going to talk a little bit about our training insights or the gaps that we know about the governmental workforce in the state. But I do want to note that this data is really limited, and it's probably too limited to be actionable in terms of deciding the trainings that are needed. So this comes from that Region 5 survey where I mentioned 35 local health departments responded. The initial takeaway is that a large portion of those 35 health departments are suggesting that they allow the use of working hours to participate in training. They report that they do have some funds for travel or registration fees for training, though the amount of funds and that sort of information was not collected. And the caveat to the first bullet, while they allow the use of working hours, the real question is what capacity does the workforce have to give their time to doing additional training, especially given the shortage or the small numbers of workers that are available in many of our health departments. 63% of those 35 health departments are providing some type of on-site training for their staff. Now, less common among the local health departments in our state are some of the things that are more evidence-informed that are impactful regarding training. So for example, including education and training objectives in performance reviews. 31% or 11 of those 35 health departments are doing that. 15 are requiring some type of continuing education. 12 are providing recognition of achievement, and 12 have a staff position or positions responsible for internal training. That wouldn't be expected in a health department of 5 people. You're not going to dedicate one person to leading training. So that's more than likely the larger health departments would have that. So what did they find were the top 5 needs among these 35 local health departments? I'll tell you that this isn't unusual, but understanding financial analysis methods is the top issue. 50% of them identified that as a training need. And that is consistent with national surveys of the workforce as well. 37% felt that they need to be able to describe the value of an agency business plan. Another 26% felt that they needed support in delivering socially, culturally, and linguistically appropriate programs and customer service. And then the numbers get a little bit smaller. So describing the influence of internal changes on organizational practice, that was 17% needed that. And then tied for fifth was supporting the inclusion of health equity and social justice principles into planning for program and service delivery, and describing the value of community strategic planning that results in a community assessment or a community health improvement plan. So we've got a little bit of insight about some of our training needs at the state level. We know a little bit about training gaps as well.
Yeah, Brian, go ahead.
I just, sorry, just a
Yes.
quick question with number one, since it's the biggest one, and we may not have more insight, but do we think that means just generally making a budget work because there's underfunding issues, or is it more specific? Because I see service delivery. I wonder, is it grant administration? Do we know more about what that means?
So I'm going to speak from my own personal experience of doing research in this field. It's all of that. It's both managing where all the money comes from, which, as you may know, in public health is really highly complex. There are certain grants that can only be spent on certain kinds of things, and understanding and keeping track and maintaining all of that becomes really quite a task. So I suspect that's wrapped up in there, but I will gladly go back and read the details of that and get you some more information. So you're going to see some similarities here. This comes out of the Public Health Wins survey. So remember, that's the survey every 3 years where they directly ask each employee who responds what their skill gaps are. And they break it out by supervisors and managers, and executives. And they ask questions that are appropriate to that level of work. So within all three of these categories, you see budget and financial management as a training gap. So I'll summarize some of the budget and financial management questions that are asked, and I'll get you guys a little more information on that. You'll also see strategic planning, creating a vision, cultural competency. Those are across all three of those categories at the state level, and they align pretty closely with some of the findings from the local health department survey as well. And this was a 2017 survey of our state health department. So an important takeaway point here is that, and you probably heard Dr. Halverson mention this when he summarized the report, the vast majority of public health workers nationally, 4 out of 5, do not have formal training in public health. And while some positions within a public health agency may not require public health expertise, this is important because cross-training, especially in small agencies, is really crucial to making sure that the foundational public health services are available and provided to all communities. So if people have basic public health expertise, they can serve some of those foundational public health service skills and areas. And it matters in terms of the capacity of our system. So what I do want to point out is that we do not have specific data on how many of the workers in the public health agencies in our state have public health training. We have national data on that. A strategic local health department and workforce assessment is really needed in our state. So again, we've got a bit of a foggy sense of what's going on, and it makes it a little difficult to predict the exact path forward, but we have recommendations that Courtney is going to summarize in just a minute. I want to go into this conversation about capacity next. So you may remember this slide from the Indiana Public Health System report, where we looked at the capacity of each of our districts. So about 70% of the local health departments completed a survey reporting on foundational public health service provision in 2018. From that information, we summarized it at the district level. And we essentially, by color, are showing you the districts that really bright districts are those that are providing less foundational public health services. The lighter color, so District 10 in the Evansville area in the south, that's one of the highest by providing 67% in their district. Sometimes that average is skewed because they have a large health department in that community. So those red ones tend to be the really rural communities across our state. This is service provision and capacity of the system, which directly links to the number of employees and the expertise of that core group of individuals. So we know that we have some capacity issues in providing the foundational public health services. In particular, we are missing epidemiological expertise, emergency preparedness expertise and capabilities, which, having just spent the last year and a half focusing on an emergency and in a pandemic, we all realize how crucial and important that is. Informatics expertise and data analytics to inform both the education of communities and the services that are relevant to meeting community needs. We saw major gaps in this informatics expertise during the response to COVID-19. And we have information technology infrastructure issues that contribute to limiting the capacity of the workforce. So, of the 6 overarching issues that were identified in the public health systems report that Dr. Halverson presented last time, there are 2 on here that really overlap with the workforce. There's a lack of specific types of public health expertise at the local level, and the local public health system is not providing the essential public health services consistently across our communities. In terms of workforce retention, public health needs to retain its valuable employees and recruit highly new skilled ones. Job satisfaction data will be helpful, but we only know a little about job satisfaction. We only have job satisfaction information from the state health department, not from any of our local health departments. At the state level, 86% of the staff that responded to the public health WIN survey said that they were highly satisfied or satisfied. However, 30% of them still intend to leave within 3 years. So we have a retention issue, which in the national workforce literature is sometimes explained by a lack of career pathways. So it's hard in a system that doesn't have clear mechanisms for changing your role over time to retain individuals. And I know the workforce community nationally is trying to identify ways to retain, and some of that is career pathways. So I don't know that 30% of the workforce of the state health department has left since they reported this in 2017, but it's something that's important to pay attention to because we want to retain the expertise within the field. Almost all available data are missing insights about recruitment issues and retention issues in Indiana's state health department and our local health departments. So while we have some national evidence about recruitment and retention barriers, we only have a handful of anecdotal reports from Indiana about which roles are the hardest to fill and other kinds of issues. So information on recruitment barriers is not consistently being collected through any of our surveys. To give you a summary of what we know from the national findings about recruitment barriers, one is a general lack of awareness of job postings. So graduates coming out of schools of public health often don't see job postings in our rural communities or other health agencies. There isn't a national repository of public health job postings. There's a misalignment between job requirements and the available workforce. So when you have a merit-based system that requires 5 years of expertise, graduates coming out of either a Bachelor of, say, Health Science Management out of our School of Public Health or other undergraduate programs don't have the workforce experience to qualify for some of the jobs. This is more of a problem with master's trained students because the jobs they think they should qualify for often require work experience that they don't have. So they'll take jobs outside of governmental public health. There's also a misalignment between the openings and the expected salaries. And so because there's competition for these trained individuals, they end up working in the nonprofit sector or other even for-profit organizations rather than working in governmental public health. Some of the salary surveys and salary studies that even I have been a part of haven't found major salary gaps, but some of the benefits that have long drawn people to governmental public health have been decreasing over time. So those competitive benefits that people used to stay within the agencies for their whole lives to enjoy. So some summary workforce considerations. The vast majority of public health workers don't have a formal training in public health. It's likely true in Indiana as well. Recent national and state workforce surveys indicate that there are retirements coming and retention issues on the horizon, but recruitment of skilled public health workers remains a challenge. One of the recommendations that came of our combined presentation today is for the establishment of a tuition reimbursement program to recruit expertise into the governmental workforce and to enhance the formal training of current public health staff. So this is a retention and a recruitment strategy for both the state agency and local public health agencies. I'd be happy to answer questions when Courtney's finished, unless anyone has anything for me at the moment. Yes, Dr. Kane.
Thank you so much. In your earlier slide, you had identified that you didn't collect data on epidemiologists or informatics, and we know that data is so critical. Was there a special reason why that was not collected?
I can't speak to that. I wasn't part of that survey development, and it's not an option in the survey. So there are some suggestions coming, and one of them is to create a commission that would design a survey that would collect consistent information annually from all of the local health departments. It may also be a function of many of those people aren't in those health departments, and so they weren't listed as an option. Some of our larger health departments certainly have those roles, but not many of them. Dr. Box?
Are there not national surveys that we could easily tag on to that are already there? We wouldn't have to design this from the ground up ourselves.
So the Public Health Wins survey is available to us that gives us a sense of what the workforce looks like. I was told that I really needed to focus on what we know about Indiana, which was why I highlighted that we don't have that information here.
Yeah, I guess my question, I didn't ask it correctly. So I would think that ASTHO or CDC or someone would have a public health survey that would get down and drill down to how many epidemiologists do you have, how many this, that could be used for local health departments that's already out there.
Certainly the Council on State and Territorial Epidemiologists has some data about the number of epidemiologists that are working. So we could certainly pull some of that information and see what they can report for us on Indiana.
Do we have any information on the race ethnic characteristics of Indiana's public health workforce?
The race and gender and ethnicity questions,
Yes.
we do not have that information. Public Health Wins asks it, but as I mentioned, Public Health Wins has only been conducted in the State Health Department and Marion County Health Department historically, both of which had less than a 50% response rate on those surveys. And currently there are 12 local health departments that are being surveyed for that information, but that's not really generalizable to the whole workforce. Dr. Box?
Can I help by reaching out to those local health departments that haven't answered you? Because we did at the state level get 52% response rate. We were third and then out of the 44 states that have done it. And that
Um,
was hard to get 52%, I could tell you.
So there is a Tableau page that identifies the response rates for our health departments, but they're unnamed, but I can connect the person who knows the names to you and see if you could help.
I mean, if that's, you have that, Pam? Oh, I'm so sorry, of course. My deputy commissioner knows everything.
Perfect, perfect.
Thanks.
If I can help, please let me know.
So, the public health wins is a national entity of some kind, is that right?
So it's a survey that's conducted by the Association of State and Territorial Health Officials in
Okay.
partnership with the Beaumont Foundation.
Okay, and the last survey, according to your information, was 2017.
And the current survey is currently being
So
collecting
that's
data
So that's every
Mhm.
5 years then,
every 3.
every 3.
Mhm. So
Okay.
they're
We're be-
behind because
They're
of the
behind.
pandemic.
Okay,
Yeah.
okay.
They
Thank
didn't
you.
want to tax the public health
Yeah.
agencies with surveys during the response.
During that time.
Turns out we're still in a response, but they're asking me
Yeah.
anyhow.
Okay,
Yeah,
thank you.
sure. Dr. Halverson?
Well, actually, I'd like to ask you, Dr. Halverson, and you both a question about the pipeline of talent. How many students are in our public health programs here in Indiana, if you know, and what percentage are Hoosiers, and or what kind of recruitment are we, doing to keep your graduates here?
So Courtney actually pulled that data and she has it in her presentation.
Oh, okay.
Dr.
That's
Halverson probably can speak to the growth too. Yeah.
I can just tell you in a nutshell, we have about 1,000 students, about probably over 90% are Indiana residents. And the vast majority of the students actually stay in Indiana, but most of them don't go into governmental public health. And it's for the reasons that Dr. Yeager mentioned. In large part, it's the mismatch between the job requirements. So they could have a master's degree in public health, but if they haven't supervised people for 5 years, they may not be qualified to be a supervisor, and the salaries are substantially lower than peer institutions for similar jobs. So it's a big issue for them in terms of being able to actually pay back student loans and go into governmental public health.
Now, Marion County Health Department does a little better job of recruiting graduates. And I'll tell you, part of it is that they have a tuition reimbursement program and their staff are able to do continuing education that is reimbursed as being a part of Health and Human Services, Health and Hospital Corporation.
I'm not surprised by that.
And I should also mention that we do have another school of public health course in Bloomington. I can't speak to the total number of students down there, but it's actually larger than ours and probably fewer yet still go into public health, governmental public health. I did have a question, if I may, for
Yes.
Dr. Yeager, thank you for your presentation. I'm just wondering, for purposes of illustration, we don't know a lot because we don't have surveys about the workforce in Indiana, but what do we know about the public health education requirements for people working at the local or the state level? Aside from the fact that we know that they have to be licensed physicians, what do we know about the experience that they have to have in public health?
For health officials,
Yes.
so the guidelines for health officials are typically that they have to be medical doctors, but very few of the health officials have public health experience. Depending on perspective, some would say as a physician, I am public health, but the training in a public health degree program is epidemiology, biostatistics, behavioral change initiatives, policy and management experience. And that is tangentially provided in medical educations. Now, many of our medical students are starting to do joint degrees. We have a joint MPH MD program, and we also have certificates or concentrations in different areas. Our IU School of Medicine has a concentration in public health. It's the largest concentration so far. So they are getting more public health experience. But when we surveyed health officials from the states, both current and historic health officials, we found that they felt like they were missing an understanding of the policy structure, how to create policy changes, how to deal with managing an organization for strategic change, how to motivate the workforce and deal with legislatures or local policymaking bodies. Some of that comes out of formal training that through some institutes, and Dr. Box may be able to speak to this, or Dr. Halverson, we have a national leadership academy for health officials at the state level that they can receive some additional hands-on training in some of these areas, which has been partly informed by the research that Dr. Halverson and I did studying health officials and former health officials. But so a lot of that leadership and management of larger organizations is missing from training in a medical school. So we don't have requirements for our local health officials that go beyond being a medical doctor. Did I answer the
Yeah,
question?
thank you.
Dr. Kane?
I want to make a comment that in some of the smaller counties, based on the salary ranges and the different grades of positions, that we lose a lot of public health employees. I'll give a classic example of a public health nurse. The gap is so wide between a public health nurse and a hospital nurse sometimes. And even if there's grant funding available to pay that nurse a higher salary, they are not allowed to pay that public health nurse a higher salary. So that's been a big barrier that our salary ranges have been like maybe 15 or 20 years ago. And so there's been no adjustments for these salaries. And also, I believe it's a lack of understanding of the skill sets that are required by the public health employees. And because of that lack of skill sets, you don't see the adjustments in their salaries. And that's a very difficult issue for a lot of local.
And
health
that salary
departments.
cap is set at the county?
It happens at smaller local health departments.
But is it the county counselors? Maybe
Yeah,
you're
who's
sitting there
setting
shaking your
that?
head.
It's the council that's setting those salaries and deciding whether or not they can add employees.
Yeah.
So it's not the Board of Health, it's not the commissioner, it's the county councils.
Yeah.
Who are typically not part of the health trained individuals that are on the Board of Health.
Mindy, what were you going to say?
And they typically what we employ as counties, and a good portion of counties in Indiana have the same system as a grid. And the grid doesn't very often get reviewed. So the grid is not market value. There's sometimes internal and external equity issues, and they're only reviewed when it's asked to be reviewed. So we're very far behind. And if we all use what's called the Oliver system grid, which a good portion do, that's what Dr. Kane's talking about. If we get a grant saying you can pay something behind somebody 110,000, nope, you can pay 50. We can't go outside of that because that is a classification system for government.
That your county councils have adopted
That's correct.
and are using.
Yes. Only off the grid positions, so things that are not gridded. So if it's kind of like a law. If it's in the law, it is the law, but if it's outside, you can have some interpretation. This grid's the same thing. So if you have, which nurses are the big one,
Yeah.
and they're sort of back and forth. Is it jail nurse? If it's not on there, they call those off the grid or exec or special ops. There's some say there. But all the other ones, most of the core ones you talked about on there are on the grid. So we have no say. And it takes a lot to get somebody to move it up, because if you move one in one department, you lose it for everybody.
Exactly.
So that will not happen very easily. That's why it's really important to get them involved in this, to see
Yeah.
how some of these need to be special applications.
Yeah, so no system in place to every 3 years review it or update it or,
It's up to you if you have money. 'Cause if there's no money, they don't review.
Now, that's the first problem. So the second problem is that if you do get grant funding and your public health department has a budget, it does not advance or increase your public health budget.
Yeah.
They will just take the money that you were initially assigned for the budget. If you get additional grant money, and I'm going to take the monies I was giving you from the city county budget and use it for something else. So although we're woefully low in terms of staffing, the additional grant funding does not help to address that gap because they're just replacing that funding from the grant monies versus the money that's generated from the city budget.
They're supplanting the fund.
They're
Yes.
supplanting the funding.
And sometimes turning away funding, as you may have seen in a recent news. One of our counties refused federal grant dollars to extend their workforce because the city council voted against I believe, $3 million grant from the federal government to increase the workforce.
The
So-
second county did the same thing
Yeah,
for the same
there's
grant.
two now.
Okay. So the councils have a lot of influence over the workforce, the salaries the workforce are receiving, as well as how many workers we have and the ability to hire as people leave and that sort of thing. What I haven't talked at all about is the workers that aren't on the books. So public health has historically used a lot of external individuals that were hired by other organizations on their behalf because there's been limits to standing up these positions in a way that would be efficient or effective to get the work done. So oftentimes they'll hire external people to do the work because we can't do it within the governmental public health structure. So there's a lot of people that I can't report on that aren't in those statistics.
Carl, yeah, I think, Brian, we've got a few questions.
Yeah, when we talk about the data where we can collect from the state health departments, but we have limited information from the local health departments, how translatable is that data considering like the actual day-to-day opportunities and obligations from a local health department compared to what happens at the state? Is that
They do
truly
very
translatable?
different work.
So is the data we're collecting from a state health department relevant to the local health departments? Are we trying to?
I would say that the
collected
work
from the
that a
state?
local, so I'm going to refer anybody who wants to look at the expectations of the specific work of each level to the public health system report. There's a table or a diagram in there that shows at the local level, these are the services they're expected to provide. I believe Courtney's memo that the Bowen Center gave you also shows what they are legally mandated to provide at the local level, but they're very different than the work that goes on in the state agencies. So to answer your question, what I think you're asking, the answer is no. They're different types of workers doing different types of work than what's happening in the local health departments.
Are we then trying to force the data? I'm thinking from like the workforce retention data where we have information about
Job satisfaction or
and
likelihood to
retention.
leave.
Yeah.
Yeah, it's not necessarily generalizable to the local health workers.
Okay.
Mhm.
Yeah, I think the whole.
Just very quickly, and I don't want to get too detailed or confuse things, but the 12 local health departments that are participating in the current PH Win survey, that was actually open to all 94 health departments to participate in, correct? And
Yes.
then they had to select to get in, which is then how the number 12 came. So and there are absolutely capacity issues and reasons, frankly, why some health departments choose not to participate in PH Wins. But I think it's important to be clear, and we can verify this, that all health departments had the opportunity to participate. That was a co-release we put out.
Is that right, Pam?
I would have to double check.
Mindy?
We were all asked.
You were all
Yeah,
asked.
We got it
Okay.
from a number of fronts.
Thank you.
And asked to do it and could do it. And I don't know that there was a cutoff or I want to say you had to be eligible. If you participated, I think they took you.
Oh, for sure.
Okay.
But I think there was a point at which they
There was.
said,
They delayed it too.
Yeah.
But there were
So,
only a few.
I just think it's important context that it wasn't a limited number of health departments
Thank
that
you.
could participate. And so it's a kind of a double response
Yeah.
issue.
Dr. Kane
And
and then Brian.
Brian was first, so I'll go after.
No, Dr. Kane. I defer.
Well, I will tell you now my most important point.
Okay, Jenny.
And the most important point is that some entities, communities feel that they do not want to be dependent on federal dollars. And as such, for fear that those federal dollars may leave in the future and then they're left with that responsibility. But unless some of you are really remarkable that I'm unaware of as part of this commission, I bet most of you pay federal taxes like I do. And I feel that the amount of federal taxes that I pay, that some of that money should come back to the state of Indiana, that someone else in another state doesn't benefit from my federal dollars. But if you're willing to cut my federal taxes by 2/3, I'm happy to be quiet about this and not say a word, okay? But I think we need to seriously look at the federal dollars that we pay. Does it come back and benefit our Indiana residents? And our money is not being benefited by some other state for what I pay and others pay in this community.
And just as a reminder, the national average is about 1/3 of local health department budgets are federal funds. 1/3 come from state budgets and 1/3 typically come from local budgets. Whereas I believe we're relying primarily on local budgets for our local health departments.
About 70%.
Yeah.
So remember what I said now.
Well, Dr. Moreau, if I just think those are important. It's the most important point. So it's hard to follow up with Dr. Kane's most important point. So this will be minor in comparison. But I do think, we talked earlier about conversations with local government officials and their associations, and I think that's all important. I think those can help. But some of those decisions may still be primarily local. The concern about reliance or supplanting, those are kind of local fiscal decisions. I think one thing where the incentives can maybe, I'm just trying to say, we could help maybe change those incentives. Sometimes applying for a fund can be more trouble than it's worth if you don't have the scale. So I don't know that we can always help, with the sort of philosophical or fiscal decision about how they fund the local health departments, but it would seem like if the smaller entities, as identified in the survey, had a resource for grant management that could sort of work across maybe counties. We do a little bit of grant management in our organization at the association. We're only 30 people, and it's a lot of work. I mean, every grant is different. I'm sure everyone at this table knows that. And that is where I wonder if somehow some type of quasi state or state supported resource to help them grant manage across would change that incentive. So they'd be more likely to seek more dollars to pull into the state. But right now they simply can't fulfill the contractual requirements. And then the second thing I just wanted to say is that I think, and this is alluded to in the discussion, we have to be conscious of the healthcare reality, the market that we're in right now and the pandemic. We're talking about workforce, and I appreciate the comments in here that we live in that context of the broader environment. We are in an absolutely critical workforce situation with respect to healthcare generally. And so the salary increases, the benefits that are needed right now to recruit individuals to the state, to quite frankly, in some cases, stay in their current positions. Wherever we were with those grids yesterday, we're way off today. And so there's a real urgency, I think, around increasing the pipeline for these positions generally. And at the same time, we look at those dynamics. But I can only imagine just in the last couple of months how much those gaps have widened. And it's probably going to continue because just from the hospital perspective, our healthcare needs are so great right now.
So Brian, does this whole discussion that you're going around here argue for a state-delivered public health system as opposed to relying on local health departments?
It would seem like there are some services where where assistance could be scaled. And I don't know if it has to be the state.
I don't understand that comment.
Well,
What does it mean, scaled?
Scaled in the sense of, if you have a local health department and there are certain requirements and certain tasks that that local health department must do or should do. And I think we've seen that there's some variation, but you have to do the basics in terms of whether it's, restaurant inspection and septic and all of those other things. You have to kind of go through that list. But what I speculate is kind of happening sometimes is there might be funding available to a particular county to say, we don't have the budget to provide this additional service, which is recommended. But if we take that, the deliverables for the grant require so much manpower to collect the expenditures, to provide quarterly updates to whoever is funding it, if it's depending on what federal agency, that it will actually cost us more internally to accept that grant than it will. So their incentive is not, the incentives aren't aligned to go out and try to really bring as many of those dollars back to Indiana as possible. So, but maybe if the county could collaborate with another county, or there was some regional, or again, it doesn't have to be a state function, it could be a quasi-state, something else that helps those counties just with that, just that function, essentially the documentation and kind of compliance with grants. I wonder if that would change the incentive so that a county would be more inclined then to go out and seek more dollars. And I don't know the answer to that, but I suspect that's part of the equation that counties go through. The juice isn't worth the squeeze to go out and get it, but it's not, we're not talking about something super complex. It's just they need help administering those grants. And I put that out really more as a question.
So that's a great answer to duck the question, don't you think?
Well, I was trying, Senator, I always did that before.
Well, I mean, we're talking about a lot of variation in terms of what goes on in each county.
Yeah.
And we're talking about not placing graduates of schools into county health departments. And so is this a little wrinkle that can be fixed with some of your suggestions, or is this an indictment of this delivery system that we have today?
I think just looking at the data that we saw, and I pulled out this sheet, one's by population.
Right.
And looking at, there are some where full-time is 0 to 12. And so I don't know how even the smallest county from a population standpoint can do that work with 0. They can't. So I think when job for a center, and I don't know the answer to this, which is why I don't have a specific answer, is I don't know what that minimum threshold is. So, but it would seem there has to be something to do all of the things, or even 50% of the things that are recommended. You've got to at least have this number of full-time, this number of part-time. And clearly there are some places where we don't have that ability. So then I think the answer has to be, do you have to regionalize it to scale it up?
Okay, so now you're starting to answer the question. You
Yeah.
said regionalize.
That could be one answer.
Okay.
Could be one answer.
Okay,
Can
I think we need to move to
I'm sorry.
Courtney and hear what Courtney has to say, and then we'll
Okay.
come back. We had time at the end for open discussion. I was worried if we had enough to say, but obviously I worried too much. So Courtney,
Thank you, Dr. Rowe. Don't
please
worry, I will
let
fly
you hear
through.
us, and then we'll come back to the questions. Hold your questions.
Okay, great. So we heard about the public health workforce, the information we have on that. I'm going to quickly share with you about the information that we maintain as a state on the healthcare workforce. We have quite a bit of information on the healthcare workforce, so those licensed professionals in Indiana. Most of those roles require state regulation, either through licensure or certification. And Indiana has recently, in 2018, put provisions in place to ensure that data and information is collected on those professionals during license renewal. In fact, Indiana is a leading state in this area of healthcare workforce data collection, and other states are seeking to follow our lead. We have access to supplemental data on the healthcare workforce, which enables us to have a complete picture of what's going on with healthcare workforce. Through a partnership with the state and the Bowen Center, we turn these data into reports and make them available for policy and planning. And the PLA, the Professional Licensing Agency, is a champion for collecting this data, and they work closely with the Governor's Health Workforce Council and our team at the Bowen Center to prepare it in meaningful formats. The council also serves as the review and approval body for the surveys. So really that's an opportunity for us as a state to structure the surveys and the information fields to gather the information that we need from healthcare workers. As a result of that statute, we have definitive data on the healthcare workforce that's collected. As a state, we also have access to additional information from other sources. So forums that allow opportunities for employers to validate that data or highlight upcoming trends and shortages and skill sets needed. And using that information, we're able to define shortages in certain geographies or among certain roles and providers. And while the information from supply is super helpful to paint a picture of the current landscape, we also have to consider information on demand. What we know from data and reporting from employers and educators is that there's acute shortages of certain types of workers and professionals in certain roles. The map on the right here displays Indiana's health profession shortage areas for primary care. Any geography that is not white has a quantifiable shortage of primary care physicians. There's additional work that can be done in Indiana in the healthcare workforce data space, such as enumerating the direct care workforce and other roles and occupations, including emergency preparedness with paramedics and EMTs, as well as other non-licensed behavioral health roles. And as Dr. Valerie Yeager mentioned, we also do not have sufficient data to enumerate the public health workforce in Indiana, but we do know a little bit about those overlapping roles that span healthcare and public health. Similar to what Dr. Kane mentioned, those public health nurses. So let's talk about those individuals quickly. From the information that physicians provided during license renewal, we know that there are 28 physicians that reported a local health department as their practice setting. Why is that not 94? It could be because of the interpretation of practice setting as to whether they provide direct patient care at a local health department. The intent of the surveys up until this point was not to do public health workforce planning, but that is a piece that could be added on in the future to identify those local health officers or those physicians that are serving on local health boards. Nurses, what do we know about nurses in public health? Very few of our nurses, 307, see public health as their primary role, but a greater number report working in a public or community health agency. An even greater number of nurses report working in school-based healthcare. Our information on nurses also identifies and quantifies nursing faculty. Full data and sources on physicians and nurses can be found in the memo that accompanied the presentation. In regards to the data that we have here on nurses, you'll see that the setting here is referred to as public or community health agency, whereas for physicians, it was a setting of local health department. This could contribute to confusion in terms of how nurses are reporting that. Potentially, if they see public or community health agency, they might think community health center or community mental health center. So this number might be higher. But again, as I mentioned, this information wasn't historically collected for public health workforce assessments, but it can be modified to do so. All right, now that we have discussed what we do and we don't know about the healthcare and public health workforce, let's talk through some of the issues that we've identified and corresponding considerations. The first foundational issue we've identified is, not surprisingly, a lack of information on the public health workforce. We know some about those healthcare professionals that practice in public health settings, but even that information, as I mentioned before, can be enhanced. What we do know is that having this information is critical to ensure that we as a state have that information available to support policy and planning for the entire health workforce, which includes public health, healthcare, and those overlapping professionals. So where might there be an opportunity to better understand the public health workforce? Well, currently the Indiana Department of Health is authorized in statute to promulgate rules related to reporting requirements for local health departments. To date, no rules under this statute have yet been promulgated. The Department of Health could consider promulgating rules in administrative code to establish workforce reporting requirements for local health departments. This could enhance information available across the state for public health workforce to inform planning. Having better data will help the state better use resources, better position the state and local jurisdictions to have data necessary to support justification for other opportunities. If such a strategy were pursued in Indiana, there are a few considerations that should be taken. Local health departments would, of course, be the primary entity that would be impacted by these reporting requirements. Therefore, they have to be considered as partners in the strategy, and they have to understand the potential value of what's in it for health departments. Also, reporting that the required reporting should be the minimum necessary to ensure a balance between availability of data and burden on local health departments. Any data collection tool should, at the minimum, collect the following information: current workforce, demand, skills required, and any barriers that the health department experiences in recruiting personnel. Next to Congresswoman Brooks' question. Although the data on the current governmental public health workforce is limited, the state is able to confidently quantify the number of graduates from public health training programs, including undergraduate, master's, and doctoral level at Indiana's public institutions. Over the last decade, Indiana's public health training capacity has increased significantly, and based on aggregate data provided by the Commission on Higher Education, Indiana's annual public institution graduation rate has nearly tripled over the last decade. At this time, it is uncertain to the extent to which graduates from Indiana's public health training programs are retained in the state for employment, and specifically whether they're filling governmental public health positions. So what could we do about it? A formal assessment of public health talent retention would be useful to inform and target workforce development initiatives. This type of analysis could be conducted by leveraging the Management and Performance Hub. Findings of a public health talent retention would be used to inform investments in health workforce development. The next foundational issue that we identified is a need for those workforce development strategies that cut across both public health and healthcare. In the healthcare space, Indiana has widely recognized shortages of certain health workers. And although information on the public health workforce is limited, we have anecdotal information that suggests shortages of public health as well. In many cases, these shortages have become worse during the pandemic. We have hospitals and nursing homes desperate for nursing and support staff, dental offices struggling to maintain dental assistants, and we've received more than 30 requests for COVID-related staffing from local health departments in the last year. So what options are out there for health workforce development? Incentive programming, as Dr. Yeager mentioned previously, is a great way to get people or skills where they are needed. The term incentive program can apply to any number of strategies that I have listed here on the slide. Loan repayment for practicing professionals that serve where there is a demonstrated need, tuition reimbursement to incentivize the achievement of additional education or growing your own workforce, scholarships which target students in academic programs of need, or tax incentives which provide state or local tax benefits to certain professionals practicing where they are needed. Workforce incentive programs have been determined to be successful for recruiting healthcare professionals into areas of need, and they could be expanded to include public health. Indiana does have some current programming under some of these categories. However, they are limited to healthcare at this time, and they do not generally include public health. For example, Indiana administers a federally supported loan repayment program through the Indiana Department of Health. That program is limited to federally defined professions, settings, and geographies, and does not include local health departments. As such, existing programming is insufficient to promote recruitment and retention of health professionals, which includes healthcare and public health, for whom there's great demand. The Commission could consider a recommendation for establishment of a state-based health workforce incentive program for professionals that cuts across both healthcare and governmental public health. Many states have developed state-based workforce incentive programs for any workforce for which there's a defined state need. These state-based incentive programs enable states flexibility to target their programming to their specific needs. Indiana does not currently have this type of program. However, the Governor's Health Workforce Council did examine this issue several years ago and supported the establishment of such a program for Indiana. Ultimately, that's what the state loan repayment program was established as a result of those conversations. And of course, implementation of any incentive program should be based on needs that are identified through the availability of that high quality data on the public health and healthcare workforce. Next, another strategy to support health workforce development is examining current licensure requirements for foreign educated nurses. Currently, nurses applying for Indiana registered nurse licensure that have received their nursing education outside of the United States are required not only to complete all of the requirements for domestic trained applicants, which includes the licensure exam, the NCLEX, but foreign educated nurses must also receive what is called a CGFNS certification. This CGFNS process requires completion of the CGFNS exam, an exam which has been deemed by the National Council on State Boards of Nursing to be a predictor of passage for the NCLEX. As such, requiring this additional exam in addition to the NCLEX may be considered duplicative and an unnecessary regulatory barrier. Indiana is only one of 6 states that requires this process. At a time when nurses are in high demand in both public health and healthcare settings, the Commission could consider supporting legislation that would offer additional or alternative pathways to licensure that do not cause additional compliance costs or administrative burdens on applicants. Another strategy to develop the health workforce is around the establishment or expansion of relationships between public health and healthcare students and governmental public health. In regards to current public health students, as discussed earlier in the presentation, we don't know right now the extent to which those graduates are employed in governmental public health. However, anecdotal information suggests there are an insufficient number of individuals with formal public health training within local jurisdictions. Community-based rotations are common in healthcare professions training programs. These rotations provide students with experiential learning opportunities in areas with known shortages of healthcare professionals for the purpose of 1, enhancing student skills, and 2, increasing the likelihood of community-based employment after graduation. There may be opportunities to allocate resources to establish or strengthen existing academic employer relationships between the schools of public health or the students and governmental public health employers. The Indiana Local Health Department Outreach Division or the Indiana Area Health Education Center regional offices, the Indiana AHEC, could serve as internship placement coordinators or liaisons between local health departments and schools of public health. For recent public health graduates, Indiana may consider the development of postgraduate public health fellowship opportunities for areas where skills are most needed. These fellowships provide an opportunity for paid experiential learning for recent graduates in areas of skill need throughout the state. The CDC implements a similar model, but similar opportunities within the state could enhance retention rates for public health talent. There are models of public health fellowships that have been implemented in other states that could be referenced if this strategy was explored in Indiana. And finally, providing public health exposure and experience to healthcare students and professionals should also be considered. Over the past few decades, healthcare curriculum has begun to integrate public health topics and considerations within student academics. However, COVID-19 pandemic demonstrated the need for a closer relationship and deeper understanding of public health within healthcare. Indiana could explore opportunities to support cross-training of Indiana health profession students with public health knowledge, skills, or experience. The Department of Health could designate a staff member to work with Indiana health professions training programs to identify opportunities to partner with public health settings, such as local health departments, long-term care, or health clinics for clinical rotations and experiential learning. The final foundational issue identified is the need for health workforce policy coordination that cuts across multiple agencies and includes both public health and healthcare. There have been recent investments in policy coordination through the Governor's Health Workforce Council, but the extent to which this work has historically included the public health workforce thus far has been limited. Oops. One potential low-hanging fruit strategy for coordinating public health and healthcare workforce policy is to ensure public health representation on the Graduate Medical Education Board. This board is responsible for allocating funding for the development or expansion of medical residencies in the state, including at federally qualified health centers. Currently, there is no dedicated public health representative on this board. And the final strategy we'd like to offer for consideration today is identifying or developing state capacity for coordination across Indiana health workforce initiatives. As referenced previously, some capacity for policy coordination exists through the Governor's Health Workforce Council. This council is a 14-member body representative of heads of related state agencies, such as FSSA, IDOH, the Professional Licensing Agency, Commission for Higher Education, Department of Education, Workforce Development, as well as key external organizational leads that represent hospitals, health clinics, and rural health. The council regularly reviews data collected on the health workforce, provides guidance on the information that is collected from healthcare professionals, and serves as a forum to coordinate health workforce policy across agencies and perspectives. The council's work to date has been informal and has been primarily focused on the healthcare workforce, but there may be opportunities to formalize and expand the council's work to include the health workforce more broadly, including public health. Of note, the council is currently undergoing a strategic planning initiative to determine future directions of the council, which may be a prime opportunity to formalize the council's work or expand it to include public health. Having an owner of policy coordination for the health workforce would strengthen alignment across disparate initiatives, reduce potential duplications of effort that may exist as a result of the current lack of alignment, and would build on momentum that already exists in the healthcare workforce space. And that is all I have for you today, but I and Dr. Yeager would be happy to take questions.
No, thank you, Courtney, and thank you to Dr. Yeager, both very informative presentations. So do we have questions that?
Actually, since you
Yes,
just first
please.
want to let you know
And
live
welcome.
streaming works. I was able to listen to.
Oh, good.
first.
Oh, good.
Very good. Very clear. Couple things that maybe to consider on the surveys when it comes to the revenue. You may want to, I think it was alluded to afterwards, may want to find out whether that revenue goes into the general fund or can actually be used in the health department. For additional manpower, there's a subset of folks you may want to look at that may be a valuable resource moving forward. That's called assistant physicians. Their physicians have graduated from medical school but did not attain a residency spot. And they'd be looking for, they would be looking for a medical experience, and I think public health might be a win-win for different ones. You mentioned about mentoring and getting people embedded. We often have in the hospitals, we have local students that come in and go through the different departments. Do you want to be a nurse? Do you want to be a doctor? Do you want to be in the ER? Do you want to be in the lab? We certainly could do that with health departments. So we can reach out to the schools. On the listening tour, I didn't hear mentioned schools or school nurses.
Schools were mentioned.
Oh, were they?
Mhm,
Okay.
yes, and we would definitely include.
Oh,
school nurses.
fantastic, fantastic. But, and then for Mr. Tabor, Brian's comments about regional. So I'm a county health officer, and we often get things done when we work with our other counties in the region. And so I think I would applaud a regional approach. And we could even do that with education of the health officers. So in my region, maybe Dr. Jones would be kind of a little bit of an expert on public health and long-term care settings. This one over here may be for industrial injuries. Just a thought, where we can do education to our health officers and then share our knowledge, at least within the districts. And then more of a district response to, because sometimes the rural counties get overwhelmed. So we gather stuff up. And the part-time issue that came up, a lot of it has to do with if they're part-time, they don't have to pay for benefits. So sometimes don't have to pay for benefits. Other time it might be job sharing situation. So you can look at it from a couple different points of view. And I thought there was something else, but I ran out of time. So I wanted to shout into my phone when I was listening on the drive-in. What about? Great presentation.
Thank you. Could I just mention that in the public health system report, there was a recommendation for some regional offices that could contain the expertise that might not be logical to place in all 94 local health departments. They could be state-run. They could come out of a state budget allotment, and then you're not relying on your local city councils to fund those positions. You'd have an opportunity to make sure the expertise is available in the local setting, and supported by the state health department, which has a lot of that expertise, but doesn't have the capacity to provide individualized support to each of their 94 local health departments currently.
One last thing, you talked about disaster preparedness. So I know you're probably going to be reaching out to stakeholders. We think about EMS, Department of Homeland Security, and actually American College of Surgeons, their trauma committee. Disaster preparedness is right one of their tenets. So we can get multiple groups to come together and then work with districts, if you will, because again, when we have disasters, it's not just one county. The surrounding counties typically will work with them and help any way they can.
Thank you. Dennis?
Yeah, I wanted to make some comments, and I'm just going to use Hendricks County as an example. Brian mentioned the data page that was looked at on size of departments and so on, and I counted up the people in our county health department, counting the physician who is a part of that, and Hendricks County is where I'm from. We have 180,000 people in Hendricks County, and that's growing. And we have 11 people counting the county health officer in that department. That, according to that chart, that makes Hendricks County in the small county size. So that's just a comment I make. I'm very supportive of the thought, and this is me speaking, I'm not speaking for all county commissioners in the state of Indiana, but I am supportive of the comments that have been made about kind of looking at doing things regionally. And Dr. Welsh, your comments about this county health department has this expertise, this one has this expertise, so on. I'm even thinking that there might be a local health department for 4 or 5 counties. There might be a local health department for, do it that way, not necessarily state-run, but these are funded by the counties in those areas. I'm all for government being smaller, quite frankly. Let's don't keep growing government. It seems like, when we start programs, we never stop programs. They go on and on and on forever, even when they no longer serve a purpose, and so on. So I'm just talking. In Hendricks County, the auditor's office, the elected auditor, the auditor's office manages all grants. So if the health department has a grant, the auditor's office has a person that manages that grant and handles that reporting and that function and the budget of it, and so on. We have a separate emergency preparedness office in Hendricks County. So speaking of disaster preparedness and so forth, that is not a part of the local health department. It's a separate function in county government in Hendricks County. And then the last comment I'll make is that in Hendricks County, there is still a county hospital that exists. It's called Hendricks Regional Health. Yeah, but it's a county-owned hospital, receives no county funding at all. It survives off of the revenues that it generates through the programs and services that they do. But the county health officer, the physician who is the county health officer in Hendricks County, is paid by Hendricks County Hospital and works for Hendricks County Hospital. All of the school nurses in the Hendricks County school systems are employees of Hendricks County Hospital. And so that's kind of the way that's working in Hendricks County. And I've kind of dug into some of this just to bring forward today. So thoughts, not everybody's going to do everything the same way, and not everybody's going to agree, but I think we can learn from each other as well. So thanks.
Thank you. Thank you. Other questions for our presenters? Yes, or comments?
I thought it was a great presentation too. And have several observations after looking at the data that you presented. And one is this, and is the fact that most of our local health departments are so small, and the investment that we've made in them is so small because it comes out of our tax budget, is because the services are predominantly being provided by the private sector, which generally would do it better and more efficiently and more effectively than through county health departments.
They're just not being provided. So when you think about initiatives that would be to change people's behaviors, while we have nonprofit hospital expectations that they provide community benefit initiatives, and I actually do research in that area, and I support some of our nonprofit hospitals in their community health needs assessments and community benefit initiatives. Those initiatives are temporary. They're not always matched to the needs of the community. While they do an assessment and they try to identify those needs, some of the decisions are based on what resources they want to invest. And so while they may have some programs that support your community, there's not necessarily any other party that's responsible to these initiatives.
And I agree with you to a certain extent, which is in the city of Madison and Jefferson County, we did a community health needs assessment years and years ago, and we identified that our top 2 underserved areas was mental health and substance use disorders. I don't believe that our county health department is ever really going to be prepared to deal with those challenges. So we're going to be relying on the private sector to do it. They're capable of doing it, but there's no financial incentive for them to do it. And, you know, being the mayor of a city and now working through budgets and understanding more about how our governments are funded, we have a lot of conflicting policies that create barriers across the state, and particularly at the local level. And all this health, I think, all the healthcare that we're going to deliver at the end of the day is going to be delivered at the local level. So that's another reason why I'm grateful to be part of this here representing the city of Madison. But it seems to me like some of our statewide policies, particularly tax policy, works against the investments that we know we need to make at the local level. And here's 2 examples: property tax caps. I know that's a hot topic. Nobody wants to pay more taxes, but we're not able to make the right investment in good government for the health of our communities when we have tax policy, for example, that works against us. That's just one example. In the city of Madison, for example, if you had $100,000, or in the county, if you had a $100,000 house, you'd pay less than $15 a year towards supporting your county health department. It's very, very small. Tax policy too, where the city or the state ended up with billions of extra resources. We refunded some of that, right? Instead of making additional investment. It seems like holistically and more comprehensively, when we're looking at delivering better outcomes, you've got to look at all types of policy, not just public health policy.
So there is an option for a tax that doesn't tax every person, but taxes a product. So for example, the proposed tobacco tax increase would generate somewhere around $350 million a year that could support many of these initiatives that we're talking about. And that's not taxing your property or your personal income. It's discouraging the use of a toxin and a cancer-causing agent. And it's the most effective way to discourage the use of tobacco.
I think consumption or user taxes is a great approach to dealing with the problem.
And I do want to address the one point that you made about the size of the workforce and who's providing it. So a big part of the public health workforce is the workforce having the capacity to work with their partners. Many of our smaller health departments don't have the time to provide their expertise to other people in the community because they are beyond capacity. So while they have the expertise, they don't have the time to support the hospital in making decisions about initiatives that would support their community. So some of this is public health as a system isn't functioning as effectively as it could because the actual employees don't have time to use their expertise to meet the needs in the community through their extension of partnerships. We'd be better at it if we had the time to do that partnering work.
Yeah, and on that, my final comment would be about expanding stakeholders. third-class cities like the city of Madison, for example, we have no voice, no appointments to our county health boards. And I think that also creates barriers and limitations. So you don't get that perspective and ownership and accountability back and forth. And at the end of the day, we're all advocating for making a greater investment. And how do we do that? By expanding, I think, expanding stakeholders. Thank you.
And I think a point that Valerie, I think it was Valerie made is, and I think Dean Halverson reiterated that, is that in most states, most of a local county health department's budget comes from the state. Here, 70% of it to 75% of it comes from the locals themselves. So it's a little bit reversed here, and that may be what we need to address, part of it. When we
And you
talk
layer
funding.
in, Dr. Box, you layer in emergencies, which generally they're not planning for from a
Yes.
staffing perspective. It's layered on.
Yes.
And it overwhelms the capacity that we have in our local health departments.
When you read any literature with regards to this recent pandemic, the whole issue is that we were so understaffed to begin with. There was no ability at the local level to staff up to the level where we needed to be. If we would maintain and provide more services across the state at a better level, then we could layer on additional people in an emergency situation like a pandemic and be able to respond better.
So we have a few more minutes before time's flying. Dean Halverson.
So thank you, great presentation, but I think to our chairs, I think this really calls for a sort of for us to back up a little bit. The workforce is near and dear to my heart, but at the heart of our issue here, in my view, is the functionality that we should expect from our public health system. And I don't believe that we've yet really embraced that issue to know what it is that we ask our public health system to do. Part of the issue that we're running into, and it goes to, Mayor, to your point about financing, it goes to issues around qualifications. We have a desperate need to modernize our public health laws, but we ought not to do that yet until we know exactly what we want our public health system to do. And part of what I think we've got to embrace is this notion around what every health department should be providing for every citizen, regardless of where you live. And right now, it is totally dependent upon where you live and how much money the local community chooses to spend on public health. And frankly, it's without regard to what the need is within public health. And so I think we have to sort of back up and talk fundamentally around what it is we want and expect. And part of that could be better informed if we had a better picture of the overall sense of how public health is done around the rest of the country. Because I think part of the difficulty is we don't really know what good looks like because we don't have other reference points. And so having that conversation around what we expect, there are some national standards, and frankly, I think we would do well to look at those standards. But for example, many people don't know, but there's actually a national accreditation agency for public health organizations. We have, I think, and I'm very proud of the fact our state health department has recently become accredited. We've got a couple of our local health departments, but that's the vast minority of our agencies. We also have a national board of public health examiners for board certification for public health workers. You don't have to be a physician to be board certified in public health. You can actually, there's a lot of people that could qualify, but again, I think we probably have now a total of 5 or maybe 10 people in the whole state that are certified. So the reality is that there are programs that exist. There are structures that we ought to be talking about. And I know we're just starting our work, and we started with workforce, but I'd almost like to suggest that we kind of come back to workforce once we figure out what we want the workforce to do. For example, I find it ironic, and I actually wrote an editorial to this effect. Here in Indiana, in order to be qualified to cut your hair, the barber that cuts your hair, and increasingly there's less of it to cut. But it takes 1,500 hours to learn how to be qualified to cut your hair. Another 450 to 500 hours to learn how to do your nails. And yet we really have no requirements that people working in public health have any requirements for training in public health. And I think that's so fundamental to who we are and what we ought to be doing that we really need to step back and talk about what it is we expect. And then ultimately we can build the workforce. I'm convinced that we can do that. And there's great models that we could look at. And I think also that there's much more that our current workforce could and should be doing. And that's the last thing I would say is that it's easy to talk about what we don't have, but what we do have are incredibly dedicated people working in public health every day, most of whom learned about public health on the job, and they're so dedicated, and frankly, they're working at a pay rate which is substantially under what they should be paid or would be paid in another occupation. So we've asked people to do a lot for not much, and it's a systems problem that we're dealing with here, and I think we ought to approach it from a systems perspective. So I meant no ill will about what we're doing, but I just feel like we have to sometimes get back to basics and what we expect.
Well, we are coming to our time. And I will say, I mean, my observation today, I mean, I really applaud some of the systems thinking that I heard. I mean, folks were talking about expertise and how that might be shared. How might that be structured? How might it be at a district or regional level? And I think we also, there are components to that system that we need to understand. So today's workforce, we've got data, there are components, then we will come back and put all those together. At the end of the day, you want to design a system. I kept thinking design, because as I heard all the questions, you want to design a system to meet the outcomes that are desirable, correct? So
Yeah,
I think that's where you're going.
Yep, that's exactly where.
Some of this needs to be the component parts as we move toward our ultimate. We got a little time with the commission. Mindy.
Just one comment. I do think it's always good to know where you're starting. And we have mixed data and for various reasons. So I do think this assessment idea is good to tailor what Dr. Fox talked about. If there's a good assessment out there, let's massage it a little bit so it fits Indiana as best as we want. But I do think we need to gain that, or else we won't know where we can go or where we will end up.
Yes.
So
Yeah, that was a big takeaway today.
easily
The foggy
somehow.
picture.
Yeah. So honestly, the Bowen Center, when I very first came here, the first thing I wanted to know is how many family doctors do obstetrics out there? How many obstetricians do we have in the state and where are they located? We didn't have any of that information because we couldn't tell whether you were still paying for your license, but you weren't practicing at all, or whether you were a family doctor, whether you included obstetrics. And so really knowing about your clinical workforce helps to know, do any of them do public health? But then Mindy, I'm so glad to hear you say that, because the thought of giving you another survey makes me want to crawl under the table and hide.
I know, it does.
But realistically, that's what I need to know. I need to know about your local health departments. I need to know about your FTEs. I need to know about their expertise. I need to know about what you cover, what you don't cover. So if we can get our local health departments interested in doing that, I think that's a great first step to help us in this.
I know it'll be difficult, but what we've had problems with before, two main issues, if we're going to consider any surveys, is that it's hard to get the verified information because the nomenclature or some of the terms are different among all 94.
Mhm.
And so when you talk about those things, the numbers aren't right. They're putting people in different categories. And so somehow facilitating that or being very clear or something, I don't know, that's one suggestion.
I'd say
And-
designing that survey with some of you guys on that survey.
Because I've done the NACCHO, I've done that Region 5, I've done public health plans, done them all. They don't ask what Indiana does, and the reason that's a problem is the statutes that we have guide mainly the staff we've had. So you have all these
Yes.
environmental or some of the nursing, but you don't have all this new, and it's not even new, but epidemiologists, informatics, and by the way, those were on there, but they're under other. Because there's only like 5 that have some stuff, but so it was never really asked. So some of those things could be tailored to now.
Great.
And I don't know that everybody's gonna buy in to do that, but I'll help.
Yeah.
We just need to facilitate it somehow to get good data, to get ground zero.
Perfect.
We
Very
can
good.
also
So that
pull-
brings us right to time, actually, if my watch is correct.
Well done.
So.
Yes. Exceptional job, guys.
A lot of food for thought. So our next meeting will be Thursday, November 18th, 2021, from 1 to 3 p.m. Our next topic that we're going to focus on is public health financing and funding. Very important topic. And with that, I'll accept the motion for adjournment.
So moved.
So moved.
Second.
Second, all in favor?
Aye.
I love doing
Nicely
that.
done. Give her a gavel.
Give me a gavel.